It's an investigating the novel compounds for myelofibrosis, where we have a couple, but one of the most important ones they were recently, in a couple years, evaluated were bromodomain inhibitions, which actually work through additional pathways where the cells gain resistance or basically drive the disease enhancements and progression, called a bromodomain. So there are a couple compounds that have been investigated in latest years. One of them reached phase 3 studies, which was a compound called Pelabresib, CPI-06110, that actually showed comparisons to single agent Ruxolitinib or Ruxolitinib with placebo in one of the largest randomized clinical trial in myelofibrosis. Basically showed impressive results with the control of the spleen, which was doubled, as well as excellent responders in terms of a dual responses, so control of spleen and symptoms. The symptom comparisons was similar or slightly better, and especially better when fatigue was removed as one of the ceiling effect of the assessments. However, that basically area has to be more explored, and because all of the other clinical trials are using the same endpoints, I think that brought us to a learning curve. What are the best endpoints we have to be using, and how do they matter to patients? What's the clinical relevance? But nevertheless, the study also showed very impressive results on regulation of some myelofibrosis, megakaryocyte distribution, JAK2 burden decline. So we do have some additional markers they are showing, including cytokines, that could matter for the disease modification. So that's something to look at, how other compounds they are also entered the clinic are going to perform. There are some from other companies. They either evaluate the drugs in monotherapies or combinations or add on to Ruxolitinib. So there are now already a couple dual BET inhibition and other molecules they are targeting. So that's an interesting topic to look at for myelofibrosis, because we certainly need to move beyond the single agent JAK inhibition.